We are live now.
Thank you.
Hello.
Sir,
You're planning to wait or start now?
sir, just the participants are joining. We just have to give them another 2 minutes.
All right.
Sir, shall we start? Suri, sir,
Yes, please.
thank you. Good evening, friends. I welcome you all for the Secret of Neurology. This is 41st episode, which we are running. It is the longest web series, especially on the neurology. And today we are very pleased to have the All India Institute of Medical Sciences, New Delhi team, those who will present their case. This is the to be very frank, this webinar, that is a brainstorming of the basic idea of our course directors, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir. I welcome you, our course director, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan sir. Those who have really designed this web series, and from the last 2.5 years, we are running this web series continuously. So today this program will end by 9:15, and our All India Institute of Medical Sciences team, we welcome to all the doctors, Dr. Achal sir, Dr. Divani ma'am, Dr. Ayush, Dr. Shaini, for this today's episode. And just give a brief introduction to our course director, Dr. Sudhir Shah sir. He is a professor and HOD with NHL, MMC, and SVP IMSR Ahmedabad. And he's a director of neurosciences in Sterling Hospital, Ahmedabad. Sir is professor and HOD, and he's a consultant neurologist to Honorable Governor of Gujarat and past executive committee member at Indian Academy of Neurology and advisor to the World Yoga Foundation also. Sir is having the interest in strokes, neurodegenerative diseases, and in epilepsy. So I welcome you, sir. And further to this, I'll give a short brief of our second course director, Dr. Lakshmi Narasimhan sir. Sir is a director and professor of Department of Neurology, Shri Ramchandra Institute of Higher Education and Research, Chennai. Sir is having a lot of awards and affiliations, and first of all, he is having a palliative advisor for ANN 2007 and A.B. Baker's Award for Global Best Teacher of the American Academy of Neurology and Best Paper Award of the American Academy of Neurology and Indian Neurology Association 2009. And further to this, sir is having a Global Atlas Award winner in August 2015, and he is the executive committee member of World Federation of Neurology. Sir has contributed the three-time executive member in the Indian Academy of Neurology and CME convener in the Indian Academy of Neurology. Sir has successfully organized the 7 consecutive clinical neurosciences program for All India DM postgraduate by the name of Shine from 2010 to 2017. So I welcome you, sir. So these are the short brief of our course directors. Now I am requesting and handing over this session to Sudhir Shah, sir. Sir, please. Sir, over to you.
Hello. Yeah.
Yes,
Thank you. And with this, I welcome all the delegates for this most wonderful and tremendously successful webinar series, that is Secrets of Neurology, Knowledge Feast for all neurologists. On a very humble note, I would like to mention that we have got excellent feedback from all the sectors of neurologists, may it be DNB neurology residents, assistant professors, teachers, practicing junior neurologists, and senior most people. And not only India, from also people from abroad are regularly attending our webinars. So that is a matter of credit. But friends, the credit goes to all of you as well as all the presenters. So this is the 41st webinar. It is running successfully every month without fail, and only this time we had to reschedule. Instead of last Friday, we are doing on the first of the month, otherwise on the last Friday of every month. And I must thank and congratulate all the speakers and institutions who have participated and shared their knowledge with all of us. Thank you once again. My major thanks goes to my co-course director, Dr. Lakshmi Narasimhan, a very, very well-read personality, a highly profoundly knowledgeable person who has contributed immensely to the Indian neurology and created a real impact. So he is working very sincerely along with me, and we are trying to impart knowledge to all the people of India and abroad. The major thanks goes to Dr. Lakshmi Narasimhan. And also my thanks are due to INTAS Global Cell team headed by Mr. Chadda, Dr. Shweta, and all others who are doing good work for logistic support and networking. So, my dear friends, today we have the Premier Institute of India, All India Institute of Medical Sciences, New Delhi, as a presenter. This is headed case is walking the tightrope of atypical demyelination. And it will be presented by Dr. Shaini Roy, who is the DM resident, senior resident student from the same department. And Dr. Ayush Agrawal, who is the assistant professor, Department of Neurology, will lead the discussion part. Dr. Divyani Garg, assistant professor, Department of Neurology, will take the discussion further to dissection of the case and maybe to differential diagnosis and all that. And we have no less a person than Dr. Achal Kumar Srivastav, who will give the expert comments and summary. So this is our Shiny Joy, who is the senior resident. Next slide, please. Devyani Garg is well known to all of us. She has 130 index publications and 30 chapters to her credit, and highly knowledgeable. Dr. Garg is MD, DM, DNB, MNMS, Associate FNMS, etc. And there's series of awards and a lot of accolades and achievements, and she's a member of so many learned bodies. And her area of specialty, as we all know, is movement disorders and neuroinfections. So she is also World Federation Neurology Junior Traveling Fellowship Award in 2022 recently, and got the travel grant for Parkinson's disease and movement disorder in 2022 and 23, and best review paper awarded in 2022, and convener Young Epilepsy Subsection Indian Epilepsy Society. So that is about Devyani. Dr. Ayush Agrawal is another assistant professor, and he has also, to his credit, more than 100 publications, PubMed Index publications, and he's chair Indian Academy of Neurology Young Neurology Forum. And who does not know Ayush, one of the most scintillating guy. And if you meet in conferences, you realize that how joyful and how full of enthusiasm this gentleman is. Professor Achal Srivastava is a personal friend, and he's having a lot of fellowships: FRCP, FAN, FANA, FIAN, FNSC, FMS, FICP. Very learned personality, and he has more than 30 paper awards, 2 orations. His faculty since 2001. He has more than 234 articles, 21 chapters, and 135 index abstracts. We all know that his special interest is ataxia, movement disorders, and genetics, and his contributions are very, very well recognized. He's also interested in neurophysiology, clinical neurophysiology with intractable epilepsy and other subjects, and he is associated with NSI, IAN, MDSI, DNA, and secretary to Neuromedicine Society. Yeah. So welcome, friends. Dr. Achal, over to you. Please handle the session from now. And thank you once again for accepting our invitation at a relatively short notice. But it was an overdue for AIMS to have come and presented. Thank you, Dr. Achal Srivastava. Sir.
Thank you, sir.
Yeah.
First of all, I would like to thank you and Lakshmi for actually asking us to present the case over here. Thank you so much. Now I'll request Ayush and Devyani to start the session. And where is Shiny? Shiny, who is our senior resident, will start the case. Shiny, you can share the screen now.
Respected faculty and seniors and dear colleagues, good evening to all. Today I am presenting an interesting case, walking the tightrope of atypical demyelination. Clinical details. The patient is a 42-year-old male patient without any comorbidities, presenting with numbness of right upper limb and lower limb for the past 1.5 months, weakness of right upper limb and lower limb for the past 1.5 months, slurring of speech and decreased speech output for past 1 month. Coming to the details, numbness of right upper limb and lower limb, actually it was acute in onset, which started in the right upper limb fingers, and gradually this numbness progressed to involve the trunk and lower limb over a period of 18 days. And the weakness, 2 days into the onset of numbness, the patient started developing weakness, which was acute onset right upper limb weakness, which progressed over a period of 7 days, so much so that he was unable to move his upper limb. And 7 days into the onset, the patient developed weakness in the right lower limb that he could not stand from squatting, or also had slippage of sepals from the right foot with knowledge. And he also had associated slurring of speech with angle of mouth deviation to the left. And 2 weeks into the symptom onset, the patient developed decreased speech output and he was communicating only with minimal words and associated with difficulty in understanding spoken language. And significant negative history, there is no history of any headache, loss of consciousness or seizures, no history of any diplopia, blurring of vision, anosmia, difficulty in swallowing or nasal regurgitation, no history of any bowel bladder symptoms, no history of any fever, joint pain, rashes, photosensitivity, dry eyes, dry mouth, recurrent original ulcerations or sinusitis, no history of any trauma, no history of any significant loss of weight or loss of appetite, no history of any recent vaccination or significant contact with animals. History continued. Past history, there is no history of any diabetes, hypertension, or thyroid disease in the past. Past history of pulmonary tuberculosis when he was 5 years of age and he was completed ATT. Personal history, he had mixed diet, normal bowel and bladder habits, and no addictions. Family history, there is no history of any similar illness in the family. Coming to the summary, 42-year-old male patient with history of pulmonary tuberculosis treated at the age of 5 years of age, now presenting with subacute onset right hemiparesis with motor aphasia, numbness of right side of the body, and right UMN facial palsy, with no other cranial nerve, bowel, bladder, cognitive, or constitutional symptoms. So coming to syndromic diagnosis, right upper motor neuron type of sensory motor hemiparesis with motor aphasia, and my localization will be in the left frontoparietal region. As a middle-aged male presenting with subacute onset right hemiparesis, most likely etiology considered was demyelination. It can be primary demyelination due to MS, NMO, spectrum disease, or ADAM or MOG, and secondary demyelination like SLE, rheumatoid arthritis, Sjogren's, or sarcoidosis. Infections that we were considered were tuberculosis, HIV, neurosyphilis, PML, and neuroborreliosis. Vasculitis also we have kept a possibility, and in malignancy we have kept a possibility of glioblastoma multiforme and primary CNS lymphoma. Coming to the examination, vitals, patient was febrile with a pulse rate of 84 per minute, regular pulse rate, and blood pressure was 124 by 80 millimeter mercury in right arm in supine position. General physical examination, there was no pallor, icterus, cyanosis, clubbing, or generalized lymph node enlargement or edema. Chest, cardiovascular system, and paraabdomen was normal. Coming to the nervous system examination, patient was conscious alert. In speech examination, fluency was impaired, repetition was impaired, comprehension was normal, naming was impaired, reading impaired, and writing we couldn't assess as the patient had right hemiparesis, which was suggestive of a Broca's aphasia. And in cranial nerve examination, visual acuity was grossly normal, visual field was normal, pupils were bilateral equal and reactive, extraocular movements were full, facial sensation was normal, right UMN facial palsy was present, palatal movements were equal bilaterally, and tongue was central. Examination continuing, bulk bilateral upper limb and lower limb was comparable. Tone, grade to sparsity was present in the right upper limb and lower limb. Right upper limb power was 0 by 5 and the hand grip was weak. And right lower limb hip was 3, power was 3 by 5, knee was 3 by 5, and angle was 2 by 5. And in the left side, it was completely normal. And reflexes, all the deep tendon reflexes were exaggerated in the right side, which plantar was extensive, and left side was normal. Coordination was normal in the left side, no involuntary movement. Gait, he could walk with circumflexion weight and with right foot drop with minimal support. Sensory examination, pain and temperature, there is 70% decrease in the temperature, pain sensation in the right side of the body, and vibration position sense were normal. There was no meningeal signs. Skull and spine examination was normal. With this, we proceeded with the investigations. CBC in hemoglobin was normal, counts were normal, platelet count was normal, RFT, LFT were normal, viral markers were negative, vitamin B12 folate were normal, and thyroid function test, chest X-ray, and ultrasound abdomen was normal. And hence we proceeded with the neuroimaging. This is the neuroimaging of the patient with A, B, and C showing T1, T2, and flare sequences showing signal changes, focal area of signal change in the right frontal region, T1 hypo and T2 and flare hyperintense lesions, and diffusion weighted image in the image E showing H diffusion restriction, and SW gradient echo showing no blooming, and contrast showing no contrast uptake in the lesion, and spectroscopy showing choline peak along with decreased NAA peak, and this neuroimaging was suggestive of a tumefactive demyelination. So we did the demyelination workup. NMO MOG was negative, ANA ANCA negative, anti-DS DNA was negative, ACE was 32, was normal, lupus anticoagulant, anticardiolipin antibody, and RA factor were negative, tumor markers were negative. CSF analysis was done. It was showing 5 cells with 100% lymphocytes. Sugar was 56 for an RBS of 106. Protein was 112. Cryptococcal antigen, gram stain culture, gene expert were negative. VDRL were negative. OCBs were negative, and malignant cytology showed occasional lymphocytes. With this, this is an approach to tumefactive demyelination. With MRI evidence of a typical acute tumefactive demyelination lesion after ruling out vasculitis, infection, and malignancy. And if there is no known MS, we can consider LP and for looking for oligoclonal bands, and then start IV MPS pulse therapy. Repeat MRI at 6 to 8 weeks. And if the patient is having clinical or radiological response to therapy, observe and repeat MRI in 3 months or sooner if new symptoms emerges. Otherwise, if further demyelinating episode, we can consider DMTs. And if the patient is not having any clinical or radiological no response, or no history of any previous tumefactive demyelination, we can consider biopsy followed by plasma exchange. If there is response to therapy, or further demyelinating episode, we can consider DMT. If there is no response, this was rituximab can be considered. So in our patients, as there was no history of any no evidence of any vasculitis, infection, or malignancy, and CSF was not showing any oligoclonal bands, we started treating with IV methylprednisolone pulse therapy for 5 days, followed by tapering days of oral steroids. And we also started azathioprine at a dose of 3 mg per kilogram per day, and the patient was discharged in the first step to follow up in OPD with further investigation reports. But 2 weeks into the discharge, the patient presented again with worsening of weakness and recent memory disturbances. And we did the repeat imaging. And this is the repeat imaging. And this is a FLAIR sequence showing new lesion appeared in the right temporo-occipital region, and the previous left frontal area lesion has increased in size, and inner hyperintensity is showing the gliotic area and surrounded by the vasogenic edema. And this is the contrast images showing punctate enhancement. So what did we miss? If we miss whether the immunosuppressant worked in this patient or not, why the patient worsened after 2 weeks? So again, here comes the patient had clinical and radiological worsening on treatment. Now we considered biopsy and plasma exchange for this patient, but imaging, we did the imaging findings, cleansed the diagnosis. The imaging finding was, this was imaging showing FLAIR hyperintense lesions with small lesion, punctate small lesions in the surrounding area showing satellite lesions, and there was contrast uptake in the punctate contrast uptake. This is suggestive of perivascular inflammation, and this is the Milky Way sign described in PML. And this was the rim core pattern in diffusion weighted imaging. In diffusion weighted imaging, we look for the B values. As the B value suggests the diffusion restriction, effect of diffusion restriction. This is a B1000, this is B2000, and this image is B3000. As B values increased, the core rim pattern become more prominent. And in this ADC image, there is central hyperintensity suggestive of facilitated diffusion due to loss of axons here. So these two imaging findings cleansed the diagnosis for our patient, and we did the CSF JC virus PCR, it came positive. So a diagnosis of PML was made for this patient. As the patient was immunocompetent, why the patient developed PML? And we go ahead with the further imaging of the patient. CCT chest and abdomen was done, which showed a mild peribronchial thickening with enlarged mediastinal and abdominal lymph nodes. And we did the EBUS guided biopsy from the lymph node, which showed non-cacheating granuloma with Schaumann body, suggestive of sarcoidosis. And AFB staining and fungal staining was negative in that. And the final diagnosis we made for this patient was systemic sarcoidosis with secondary immunodeficiency causing PML. And we treated the PML initially with 5 cycles of Plex, and then started on TAP, mirtazapine, and mefloquine. Only case reports are available. We continued TAP azathioprine, and on follow-up, the patient's symptoms improved. His motor speech also improved, and he is currently able to walk with an MRS of 2. And this is the follow-up image after 6 months. Actually, it is showing significant resolution of the lesion that we already saw in the left frontal region. So this case, as it was been interesting, we published it. Learning points from this case: in any patient presenting with tumefactive demyelination, PML must be considered even if the patient is immunocompetent. Imaging features suggestive of PML are U-fiber involvement and typically no mass effect or contrast enhancement, non-responsiveness to first-line therapy, and worsening of lesions and characteristic Milky Way sign along with JC virus PCR positivity clinical diagnosis in our patient. And apart from the first-line investigations, all patients should undergo CSF JC virus PCR, CT chest abdomen, or whole body PET and evoked potential testing before a diagnosis of seronegative tumefactive demyelination. Thank you.
Thank you, Shiny. If there are any questions, we'd be happy to answer them. And as Shiny emphasized, what we want to literally drive home in this is that tumefactive demyelination is something that is a diagnosis that is gradually evolving, and it's something that came into the picture in the past decade. And any lesion that is seen on the MRI predominantly involving the white matter and is more than 2 centimeters in size is considered to be tumefactive demyelination. And initially, before the diagnosis of NMO and MOGAD, all of those came, we thought that tumefactive demyelination was just a variant of multiple sclerosis. However, now with evidence accumulating, we find that tumefactive demyelination can also be seen in neuromyelitis optica spectrum disorder, MOG-associated disorders, sarcoidosis, PML. So if we're finding tumefactive demyelination, just ruling out MS, NMO, and MOG is not essential, is not the end. You should keep evaluating, and most likely if we are stringent enough to look for a cause, we'll find it without the need for a biopsy.
Okay, thank you, Shiny and Ayush, for an excellent presentation. I'm sorry my voice is sort of giving out today. But Shiny, can you please go back to your slide on your possible, before the differentials, on your syndromic diagnosis? Yeah. So what are the structures involved in your patient?
As the patient is having right hemiparesis with aphasia, corticospinal tract, we can say right hemiparesis with the right human facial involvement, corticospinal tract above pons, left side. And as the patient had motor aphasia, the patient is having Broca's area involvement. And numbness in the right half of the body, it can be the sensory tract involvement. Most likely,
Okay, so but above the pons, we have both cortical and subcortical structures. So between those, which do you think is more likely to have happened in your patient?
actually, initially I thought it happened subcortical. It can be because the patient had motor aphasia. I think cortical involvement was also there in this patient, along with subcortical involvement or numbness.
Yeah.
Sorry to interrupt. Madam, Dr. Shiny, do you think the localization of aphasia is cortical and the corticospinal tract is subcortical? Is that what you are trying to tell?
Yes, sir. I think what I meant was the corticospinal tract involvement above bones, we can say, because the patient is having human facial palsy, so it is above pontine region. Corticospinal tract anywhere from above bones.
Can you club the sensory also together and put it in
Sensory,
one single place? Where you get a sensory motor hemiparesis, where do you get?
sensory motor, sir.
In all your lesions which you showed, which of the lesions do you think is responsible for the clinical thing?
Clinical, sir. It is the right. I think front.
Yes, Devyani, you continue. I was curious to know, are
Yeah,
there the different lesions which are expressed or different places, or going to explain based on that, or is it
yes, sir.
which of that? I just wanted to, I'm curious to
Yeah,
know.
even I wanted to have the same discussion actually.
Hmm.
So, yeah, Shiny, what we are trying to elicit is, do you think that all your the deficits that the patient had can be explained based on predominantly, say, a subcortical pathology, or are you invoking cortical pathology over and above a subcortical pathology? Or is this motor aphasia a form of subcortical aphasia?
Yes, ma'am. Subcortical. Can be subcortical, I think.
Okay, so but usually when we have patients who have, let's say, a dense hemiplegia, we see that a lot, right? We see that in patients who have stroke, and then you also find that they have sensory involvement. How do you explain the sensory involvement in such patients?
Sensory involvement can be due to usually dense hemiplegia happens in the internal capsule level. So
Right.
maybe thalamic radiations, because of the thalamic
Yeah.
radiations, we can
So
explain
usually
the
we use that to explain sensory motor
Yes,
hemiplegia.
ma'am.
Do you think that was happening in your patient, or are you invoking the involvement of the sensory motor cortices to localize?
Then the answer
We can
patient is
discuss the points for and
most likely
against.
it's subcortical, ma'am.
Sorry, I didn't hear that.
Maybe subcortical, ma'am. Subcortical lesion.
Okay, okay. And so your aphasia is the only thing that is sort of pointing towards a cortical pathology. What are the other features that you might find in involvement with the cortex?
Aphasia, apraxia, seizures.
Yes. So if you had a sensory cortical involvement, you would expect certain other findings which your patient did not have. So it is more likely that this is subcortical
Okay.
in entirety, right? And another, then go on to your differentials list. Yeah. So you have kept immune-mediated and inflammatory as the topmost pathology. Can you tell us, based on the temporal profile of this patient, why this was kept as the most, as the first etiology?
Because the patient is middle-aged male, ma'am. Middle-aged male presenting with subacute onset right hemiparesis. So vascular stroke is not possible. Then the second most common etiology for this will be demyelination. So only I kept the demyelination of the first possibility for this patient, because now constitutional symptoms to explain the infection, no history of any significant loss of weight or loss of appetite for HIV or TB, or no other features suggestive of any TB. Infectious etiology was not there. Constitutional symptoms was not there. So I felt that maybe the patient is having demyelination.
Yeah. So what is the usual temporal profile in demyelinating disorders? How does the symptomatology evolve usually in terms of time?
Ma'am, usually subacute onset and onset to nadir will be there around 21 days, or according to the
Okay, so it will be usually in days to weeks.
days to weeks. Yes, ma'am.
Yeah, and then usually a plateau is achieved
Mm.
unless it's a progressive demyelinating disorder. And then usually there may be some improvement. So that is the usual temporal profile.
Okay, ma'am.
In your patient, it was essentially, it was evolving over a few days.
Yes, ma'am. It was evolving on a few days, actually 20 days, 21 days.
Up to 3 weeks or so.
Yes, ma'am. 3 weeks.
So you achieved an nadir by 3 weeks.
Yes, ma'am.
Okay. Dr. Ayush, any further questions that you want to take?
I think your discussion with Shiny has already answered two questions that were asked, that what is the history that was suggesting demyelination. And there is another question asked by Dr. Bhadu Danvir, who's asking, was any workup for primary immunodeficiency done? So immunoglobulin levels we had done, which were normal, and patient was negative for HIV. After we found sarcoidosis and we treated, and the patient improved and had no other history of opportunistic infections. So we did not feel that any other further investigation for cause of immunodeficiency was required. So no, that was not done in great detail. Since we're on the differential diagnosis slide, we actively also ruled out neurosyphilis because that is a great mimicker that can present in a variety of ways. And this case taught us a lot in the sense that initially we were okay with the patient being seronegative and tumefactive demyelination. But now for all patients that come, we either do a PET or a CT chest and abdomen to look for a pathology that might be hidden somewhere before we just give a blanket diagnosis of seronegative demyelination. Dr. Suresh Kumar is asked whether colonality panel was done in CSF to see for the CD4 to CD8 ratios. I don't think that was done because the cell count itself in the CSF was negligible. So this was not going to add anything.
Shiny, can you elaborate a little bit on the two very important radiological signs that you have shown?
Yes, ma'am.
Can you describe the Milky Way sign first in detail, then the rim core pattern? Because those are two very important signs. If you find them, then we have to think along the lines of PML.
Yes, ma'am. Actually, this Milky Way sign is due to the CD8 cells causing perivascular inflammations, and this perivascular inflammation is getting enhanced in contrast, and this will be seen as the punctate enhancement. So there will be a hyperintense lesion surrounded by this satellite lesions, small lesions, and these small lesions are considered to be due to the perivascular inflammation by CD8 plus cells. And this is the Milky Way sign. And the other sign is rim core pattern in diffusion weighted imaging. In diffusion weighted imaging, actually B value is there. B value will tell us the strength of diffusion restriction. And as B value increases, this is B value 1000, this is B value 2000, and this is B value 3000. As B value increases, this core with rim, the pattern will be more enhanced. And this is suggestive of PML. And this ADC is showing hyper intensity because the inside of the lesion, there will be facilitated diffusion because of the loss of myelin and axons.
This diffusion B values that you're talking about, can all of us access them on our machines? Or do we have to ask the radiologist to specifically pull out the B values and look at this?
Normally, usually for every MRI, I think it is only 1000 has been done. So we will have to ask for this.
Yes.
See this sign.
So that is important, that normally we will see at the B1000 value.
Yes.
But we have to go back to the radiologist and ask them to look at higher values to elicit the sign. Okay. And Shiny, can you also elaborate upon the PML types, the classic PML and the inflammatory PML?
Just
classic.
Before we do that, Shiny, can you just go back to the previous slide? There's one more thing that you can emphasize on. No, the next one. So if we look at the MRI here, despite the lesion being quite large, we don't see any mass effect or any perilesional edema around such a huge lesion. So otherwise, when we see an MR like this, a few things that come up in the mind, which were also discussed by Dr. Shiny, was that, is it a lymphoma? Could it be a glioma? So if you see a lesion which is large in size but is not causing a significant amount which would be attributable to the lesion of perilesional edema or a midline shift, it is likely to be a demyelinating pathology. So although this scan might look a little scary, we must analyze it in detail before we decide that this is a case that is fit for surgery, biopsy, radiotherapy, and the likes. Yeah, Shaini, you can go back to Dr. Divyani's question about PML and answer that now.
Yes, ma'am. Two types of PML are there in classic PML and inflammatory PML. In classic PML, actually, we will see the hyperintense lesions, but there will not be any contrast enhancement, no mass effect. But in inflammatory PML, usually happens in inflammatory iris syndromes along with iris. Actually, there will be, when you are treating the underlying condition, the underlying HIV or whatever it is, the cellular reaction will increase and it will cause a hyper-inflammatory state with hyperinflammation. And at that time, that lesions will have can have mass effect, will have gadolinium enhancement in inflammatory PML. So it
Yeah.
is iris overlap.
Correct. And so the important thing is that routinely when we see these large lesions which don't have mass effect and don't really have any contrast enhancement, that is the time to start thinking of PML. But also remember that a very small percentage of PML, classic PML, that is the non-inflammatory or the non-iris related PML, can have a minimal contrast enhancement in up to 10% of patients. And when we have the inflammatory PML, then of course, because it is a hyperactive immune system, then the contrast uptake will be there. And that will help us to differentiate these processes. And very interestingly, in this patient, although we didn't find classical immunodeficiency, but because in PML, we usually, when we think of the classical immunodeficiencies, it has been described with lymphoproliferative disorders initially. And then the chemotherapy agents used to treat those lymphoproliferative disorders. And then we had the whole MS era with all the natalizumab and other MABs coming in, and DMF also, that have been associated with an increased risk of PML. However, in this patient, you found sarcoidosis as a potential immune disorder that predisposed the patient to PML. So can you tell us of some other conditions apart from the classical HIV, lymphoma, natalizumab situation where one should explore the possibility of PML? And also, has it been reported in so-called immunocompetent people also?
Yes, ma'am. Actually, in immunocompetent PML, sarcoidosis actually association has been there and case reports are there. Because they are thinking maybe because of the CD4 cytopenia that is happening because the CD4 in the peripheral blood will go and form the granulomas. So maybe because of that secondary immunodeficiency and causing this PML. And also there are case reports having sarcoidosis having other immunodeficient disorders like other cryptococcosis. Like other opportunistic infections in sarcoidosis are well described.
Yeah, I think we have a few questions from the audience. So Dr. Shreyasi is asking, is there a risk of the PML worsening with continuation of immunomodulation? And is there any vaccination or other measures needed to prevent other secondary infections in the face of secondary immunodeficiency and further continuation of immunosuppressive therapy? Dr. Ayush, I think if you can take this question.
Yeah. So very nice question, Dr. Shreyasi. So I think that is because of the conundrum that you've just pointed out, that is why we named the title of our presentation a tightrope walk. Because on one end, we were dealing with somebody who was immunocompromised. And on the other hand, if we did not treat this patient with, drugs like corticosteroids, plasma exchange, and the lot, then the cause of the immunosuppression would not go away. That is, we had to treat sarcoidosis despite the fact that sarcoidosis was causing immunosuppression in this patient. So it was extremely difficult. A lot of discussions went on and the patient was in the ward. And then we finally decided that we had to treat. Guidelines also suggest that if the patient has not responded to methylprednisolone pulse, the next line of therapy is plasma exchange. So thankfully, our patient did respond to plasma exchange because otherwise the next treatment would have been rituximab, which would have been even scarier in the background that you have just described. So that is why we gave the patient plasma exchange followed by oral steroids, concomitant azathioprine as a steroid sparing agent. And everything went well for us and the patient gradually improved as has been described. With regards to the second part of your question, that is vaccinations. Live vaccinations could not have been given to the patient because the patient was anyways immunocompromised. And thankfully, once the patient had recovered, they were not required. And the role of presumptive vaccination is not really described unless and until the patient is getting drugs which are monoclonal antibodies like rituximab. So that was not given to the patient.
Yeah, so just adding on to that, generally when we talk about treatment of PML, so it may actually depend upon what the underlying disorder is. So for example, if it is natalizumab associated PML, we know that we have to discontinue it, and sometimes even we give patients plasma exchange so that the drug is washed out. And if the PML is got an iris element to it, then we often actually give steroids or immunosuppression to take care of the over-exuberant inflammatory response. Okay, so we have another question. What was the titer of CSF JCV in your patient? I don't think a titer was done.
Titer was not done. It's not usually available also in most laboratories. And the next query by Dr. Suresh Kumar is that sarcoidosis was associated with PML per se in our patient. As described, rarely sarcoidosis can cause lymphopenia because of the lymphocytes being all aggregated and segregated in the peripheral lymphoid tissue, because of which the patient can have immunosuppression. So that was the cause of the PML in our patient and not the primary treatment with immunosuppressive therapy. I'm sorry, but I can't understand the question posed by Dr. Atif, who's asked that I wish to know your experience of CNS demyelination due to tuberculosis without significant tuberculomas. I'm sorry,
we haven't seen any such cases of demyelination associated with TB, meningitis, and other things I think you mean. But maybe you can clarify the question by typing it again. A few other questions are there. So does the MRI finding of PML differ in immunocompetent and immunocompromised patients? Yeah, I think Shiny, you can answer this question. Is there really any difference in the immunocompetent patients? It's extremely rare for PML to occur in immunocompetent patients per se. And also calling patients immunocompetent will really depend upon the extent to which that competence has been tested. So with that caveat, is there any difference in the MRI, or they just look exactly as we have described?
Maybe, ma'am, in typical PML, there will not be any contrast enhancement, but patients, I don't think.
That's right. Occasionally, if in the immunocompetent cases, a little bit of contrast enhancement has been reported for the same reasons, that it is actually the immune competent state. And any role of IVIG in this patient? Dr. Ayush?
IVIG can be given, but plasma exchange is what is described and been mentioned in all reviews that have come out, including the one that came out in JNP in 2013 and very recently in 2017. They say that if the patient has not responded to high-dose steroids, plasma exchange is the second line followed by rituximab. If IVIG needs to be tried, it can be given, because recently in 2022, the role of IVIG was found in MOGAD, which is a very common cause of tumefactive demyelination, but the exact potency is not yet known. Another, Shiny, you can perhaps explain, since we are on the imaging slide, that you explained the clinical features, which of these lesions is likely to have caused the hemiparesis as well as the aphasia in your patient?
Yeah, that is the left, as initial slides, I have shown the image. That left subcortical and frontal subcortical involvement was there. And in PML, there will be extension and expansion of the lesion will be there. Expansion and extension, like extension, it will go through the white matter tracts downwards. So maybe because of the subcortical involvement only, the patient had sensory motor involvement. I think so.
Yeah. And having said that, another thing to note is that because PML can go very close to the cortex, as you can see in this MR also. So sometimes either because of disruption of these very close subcortical regions, we know that sometimes patients with PML can present even with seizures, which is classically considered to be a cortical phenomenon. So just keep that also in mind. So I think we have no further questions from the audience. I guess I'll just summarize the main points in my horrible voice, but yeah, just forgive me for that. So basically we have this patient who had presented with a subacute presentation with a hemiparesis in association with aphasia probably of subcortical type. And the MRI features were in fact fairly, initially, in fact, it looked like tumefactive demyelination and he was treated as such. But despite an initial response, the patient came back with a clinical and radiological worsening. The radiology at the second go revealed two important signs, that is the Milky Way sign and the rim and core sign. And that is what gives a clue towards the possibility of PML, subsequently confirmed on the CSF-JC virus serology. And the patient responded to treatment, but since the classical features of immunocompromise were not there, the case was further explored for other less common immunocompromised states, and that revealed the presence of sarcoidosis. And finally, after walking this tightrope of immunological modulation versus sort of not giving too much and not giving too less, the patient managed to do well and come out of it. So congratulations on the case and congratulations on the discussion. I think the important learning points were that don't give up the chase for looking for an underlying immunocompromised state in apparently immunocompetent patients who come in with PML. And the second is to remember the classical radiology that is associated with PML, which can be the clue. With that, I would like to invite Professor Achal for his remarks.
Yes, that is right. Sometimes we say that you should have a tangential kind of thinking, out-of-box kind of thinking. So those things really work on many occasions. Here we did have a very tight rope whether to give whether to give these kind of medicines or not. In the end, the result was good, I will say. We did walk that tight rope and were successful in the end. And that is also evident in this case got published as well. I think people had a very good learning from the case, and which is also visible from the participation by the audience. I think we should have a prize per question as well. Had there been a prize, I will give it to Shreyasi. That was a very nice question to ask, and that is the actually crux of the case. So I think we can, from my side, we can stop here. And I will request Dr. Lakshmi Narasimhan for his comments, or if Dr. Shah is there, then he can make a comment. Yeah.
Yes. Thank you. Thank you so much for a wonderful episode. In fact, a lot of learning points, the Milky Way sign, the rim core sign, the way in which differentiation between inflammatory PML and classic PML, lot of learning points for the youngsters. I should really thank for an intellectual feast from the All India Institute. As with the excellent presentation from Shiny, very good discussions from Ayush and Divyani. The entire episode was all the 60 minutes which we spent here was really worth. Thank you so much for Achal for organizing such a lovely episode. Thank you so much. Thanks all the people who participated, both from India and from abroad. I thank every one of you. And thanks for a lovely show. And now I request Professor Sudhir Shah, sir, are you available? I think sir is not
there. Actually, he's there at
sir
Bombay.
Okay.
I think he's not available.
Arun Shraddha for the Thanksgiving. Thank you.
Thank you. Thank you, sir. Thank you. Today, it's really a great day as we are completing our 41st session of Secret of Neurology. I, Arun Chadha, Vice President, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 41 months. I would like to thank our honorable course director, Dr. Sudhir Shah, sir, and Dr. Lakshmi Narasimhan, sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. We are very thankful to young neurologist, Dr. Shiny Jai, for case presentation. Further to this, I would like to thank Dr. Ayush Agarwal and Dr. Divyani Garg ma'am for all the symptom evaluation, investigation, and the other things. Thanks to Dr. Achal sir, Professor of Neurology, All India Institute of Medical Sciences in New Delhi, for sharing their experience in this case and providing the important learning points and proceeding of this unique case. Once again, we are very thankful to all of you for your gracious presence. It's being a pleasure being with all of you in our 41st session of Secret of Neurology. And thank you for your presence. And we will meet again on 29th December with yet another most awaited next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you to all of you. Thank you very much. Thank you, sir. Thank you very much.
Thank you all.
Thank you. Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Sport team,
Yes, sir.
you can close the session.
Sure, sir. Sure.
Thank you.
You're welcome, sir. Good night, sir.
Good night.